Good morning, everyone, and thank you, Manoj, for this opportunity. So, DME on OCT can be classified, as you all know, into spongy, cystoid, sciatic, and any of these can have subfoveal detachment or the surgical causes of either epiretinal membrane or vitreomacular traction. Pathogenesis, again, it's because of the increase in cytokines because of advanced glycation end products that gives rise to an altered blood-retinal barrier. Role of laser has been studied, and currently it's limited to non-center involving diabetic macular edema. And the drugs currently available for anti-VEGF, you have the Avastin, Lucentis, and the Eylea injections. The first line of therapy currently, the gold standard for center involving DME is anti-VEGF therapy. It can be either ranibizumab or the aflibercept, which was the evidences coming from the protocol I, RISE, RIDE, and the RESTORE for ranibizumab, and the VIVID and VISTA for the aflibercept. The protocol T was a direct study, direct comparison of all the three anti-VEGFs of aflibercept, ranibizumab, and bevacizumab. And as you can see over here, the statistically it was not different, but the best response was with the aflibercept of plus 13.3 letters, and the lowest was with bevacizumab plus 10 letters. There was a Cochrane meta-analysis study, and they concluded that aflibercept confers some advantage over the other two molecules at year 1. There are anatomical benefits of ranibizumab over bevacizumab, but little difference in the functional outcomes. But these results from these randomized trials may not apply in real-world practice, as patients are most often undertreated and under-monitored. The other evidences have come from the RISE and RIDE trials, which have concluded that the eyes that received Lucentis were less likely to progress in the diabetic retinopathy severity, and ranibizumab slows the progression of retinal non-perfusion in patients with diabetic macular edema. The VIVID and VISTA gave us evidence about the aflibercept, and they concluded that again, aflibercept receiving eyes were less likely to progress in diabetic retinopathy severity score, and it slows down the retinal non-perfusion. The current regimes that are right now available with us, we have the monthly dosing, we have the PRN or the as required dosing, and the third one that is off late come into the picture is the treat and extend dosing. The monthly dosing has got its own disadvantages and advantages. Right now, it's not practical because of the monthly dosing and the monthly visits the patient has to undergo. The risk of infection with each injection. There's a huge economic burden on the patient, and it's a time-consuming procedure as far as the patient is concerned. But the advantage is that it has the best efficacy of all the anti-VEGF regimens. Coming to PRN dosing, again, it's an anti-VEGF that is administered based on the treating physician's discretion, based on the changes in the visual acuity and the OCT changes. So you start off with a monthly dosing, and when the stability of vision is achieved, then you monitor patient on a monthly basis, and as and when there's a decrease in visual acuity or changes in the anatomical outcome in OCT, you start again on a monthly dosing till the stability is achieved, and then you can stop the injections, but the monthly monitoring continues. So the protocol I was a study with 4 arms, but I'll stick to the 2 arms of ranibizumab with prompt laser and the deferred laser. Prompt laser was done at 4 weeks, the deferred laser was done at 24 weeks. And the monthly injections of ranibizumab were continued for 6 months, and it was continued even further till the visual acuity reached 20/20, or the central thickness was brought down to less than 250 microns. Or if the change in between 2 consecutive visits was less than 10% in central macular thickness. The retreatment criteria was you start the treatment again in the monthly monitoring phase if there is a drop in vision of more than 10 letters of the central thickness is beyond 250 microns. So if you can see here, this clearly demonstrates the fact that if you treat aggressively in year 1, as the years follow, the number of injections required is reduced. So in year 1, you have about 8 injections and 9 injections in both the arm. And in year 5, you can see no injections were required. The advantages of the PRN is the robust visual acuity gains, stability, and substantial reduction in the number of injections. But the downside to that is the follow-up still remains. So this brought us to the TREX regime, which was already in place for AMD, and the concept was taken from AMD, extended monitoring or no treatment intervals. Treatment and monitoring frequencies are tailored to the patient's response. It's a commonly used regime in clinical practice and requires further evaluation. The rationale to use it minimizes the number of office visits and injections, minimizes the occurrence of new intraretinal or subretinal fluid, minimizes the risk of injection, associated side effects, and minimizes the cost to the patient. So in treat and extend regime, you again start off with a monthly dosing, and thereafter, once the vision stabilizes or the OCT changes, OCT is coming back to normal, then you increase the frequency interval from 4 weeks by 2 weeks, every 2 weeks. So it goes to 4, 6, 8, etc. But at each visit, again, you monitor the patient as well as you give an injection till a maximum of 12 weeks. And thereafter, if at all there's a recurrence of fluid or if the vision drops, then you go back to a monthly dosing and again start off with every 2 weeks increase in the follow-up. So unlike a PRN schedule, the clinician does not have to wait until a macular edema is worse before treating this patient. And as you all know, chronic macular edema leads to irreversible visual loss. So preventing recurrence of edema can potentially preserve the visual acuity in the long run. So RETAIN study was a randomized trial that studied this treat and extend regime. They had 3 arms. One was the treat and extend ranibizumab with laser. Another one was the treat and extend ranibizumab monotherapy and the PRN ranibizumab monotherapy. And as shown in this graph over here, the results are not statistically significant between the 3 arms. And whatever the benefits that were seen at month 12 has been carried forward to month 24 in all the 3 arms. This is another study called the TREX DME study. Again, it had a monthly ranibizumab, a treat and extend ranibizumab, and a treat and extend ranibizumab with a guided laser. So here you start off with a thicker retina on a monthly dosing schedule, and as and when the thickness reduces to around 325 microns, that is taken as the new baseline. And the treatment is still continued till it becomes less than 250 microns. And thereafter, you start increasing the follow-up period by every 2 weeks till a maximum of 12 weeks. So the graph 1 shows you the number of letters that have improved. Graph 2 shows you the central macular thickness from baseline, and the third one is a treatment interval. So they have concluded that the TREX dosing can be titrated based on the individual patient's response. There was a similar visual and anatomical outcome were obtained in all the 3 groups, and reduction in the treatment burden as compared to the PRN, as compared to the monthly dosing was seen in the TREX regimen. And the benefits that were seen at the end of year 1 has been carried forward to year 2 with the TREX and the laser-guided treatment regimens. You can see over here the number of injections that were required in the TREX cohort as well as the laser one was only 18 and around 18 injections. But the treatment interval was much higher as compared to the monthly cohort, which was around 4.3, as compared to the TREX, which was around 6.2. Coming to the resistance is quite commonly encountered in DME because of the complex pathophysiology. Protocol I had 75% patients after 4 loading doses that were incomplete responders. Protocol T had a failure criteria for supplemental laser at 24 weeks, and 27% of aflibercept, 37% of ranibizumab, and 41% of bevacizumab patients showed features of treatment failure. So what do you do in a case of treatment failure? One, you can switch between the different anti-VEGF agents, or switch to a steroid, or you can try a combination of both, or you can alternate between an anti-VEGF and a steroid on a monthly basis. And finally, you have to revisit the diagnosis and look out for any non-perfusion characteristics or any surgical causes for the edema. So for the treatment evidences for this, it's coming from the ROTATE trial, but it was a prospective randomized trial, and they switched from bevacizumab to ranibizumab, and they concluded that there was improved vision as well as anatomical outcomes, but there was no difference between the 2 PRN and the TREX regimens. The next one was a switching of the molecule to aflibercept in patients who were treated with either the steroid or the ranibizumab. It was a retrospective study, and they showed that the aflibercept improved the central thickness and the vision. However, an early switch was recommended. The third one was again a retrospective case series, and they concluded that there was a 25% decrease in central thickness in 9 out of the 11 eyes, and 7 eyes gained vision in those patients that improved vision, used aflibercept. This was yet another aflibercept switch study, which was brought in from, which came from Australia, and they treat the resistant patients who received 4 injections of bevacizumab were shifted to aflibercept, and they showed an improvement in functional as well as anatomical outcomes. So the current Royal College guidelines say that you have to give monthly anti-VEGF injections till stabilization of vision, and thereafter you can switch to a PRN dosing. The Indian scenario, we have the REVEAL study, and they concluded that the ranibizumab was superior with or without laser as compared to laser alone. And finally, you have to tailor the regimens to individual patients. So in conclusion, it's the surgeon's preference and the patient's affordability that comes into the picture while selecting the right anti-VEGF agent. Protocols can be personalized. To begin with, you can start off with a monthly dosing, dry out the macula, and then shift to an either TREX or a PRN regime. And finally, switching between anti-VEGF agents, especially when the vision is very good, you start the treatment early, then the patient can be preserved in a good vision right through. Focal laser still has a role, especially in non-center involving diabetic macular edemas. And outcomes depend on the starting visual acuity, and proportion of suboptimal or non-responders of approximately 10 to 20% should be always kept in mind while treating DME patients. Thank you.